All right, well, welcome everybody to AMCHP's February all-member national MCH policy call / COVID-19 town hall. We are going to have lots of information to share today, so I'm going to go ahead and get started right away so we can at least go over some logistics. Olivia, could you forward to the next slide, please? Let me see if I can get. Thanks. Okay, now I can do it. So of course, you'll be able to unmute during the Q&A. And if you have a question for the presenters, please also type it in the chat box and choose all panelists and attendees so everyone can see your question as well. This call will be recorded. If you have any difficulties during the call, you can email Jess Cohen, that's jcohen@amchip.org. Our agenda for today, I'll start with a policy update. We are joined by Laura Kavanaugh on behalf of the Maternal and Child Health Bureau. Then we will have a CDC update. There will be time for us to hopefully get some state sharing. We'd love to hear a little bit more about how you're utilizing Title V for COVID response, and then any other Q&A. So I'll start by sharing that we have recently approved the AMCHP 2021 federal policy agenda, and I'm not going to read through all of it right now. There is a link to it, and it will be on our website. But the thing I really want to highlight is that our ask for this year is going to be for $750 million for FY22. That's about a 5% increase over last year, and kind of in line where a lot of folks in the health community are asking for their programs for an increase. No one's asking for decreases, you can imagine. We also, as AMCHP, have reiterated our request for COVID relief. As you've probably heard, there's further discussion going on in Congress right now. President Biden has a pretty ambitious COVID relief plan that he's put before Congress as a framework for what he'd like to see. And so as part of that, we've really highlighted 3 programs. And the first is, of course, the Title V block grant, which did get allocated $500 million in a proposed bill in the House, which did pass the House, but never went through the Senate. So it never passed into law. But building upon the fact that that was passed in the earlier version, we are reminding the members of Congress that that was included before. Another program we are continuing to support is increased funding for CDC's surveillance for emerging threats to moms and babies. We know that many of you are already using this program and have adapted it for COVID-19. And then finally, for MCHB, the Maternal, Infant, and Early Childhood Home Visiting Program, knowing that the needs are greater and different during the pandemic, and we want to make sure that we are able to continue first serving the families who are already in the program, as well as recognizing that given the economic downturn and other conditions, there will be potentially more families who could also be eligible for the programming. And so right now, Congress is considering how they're going to pass COVID relief, and you may have heard that they've started consideration of the budget resolution, because that sets up the process for reconciliation. And budget reconciliation is one of the times where the Senate can kind of get around the filibuster rule of having 60 votes to pass something, because there's pretty much an assumption that whatever bill they come up with probably won't be able to get 60 votes. There's obviously a very divided Senate right now, being that it's 50-50. So the process, the initial budget resolution has passed the House, and I believe still in consideration in the Senate. But once that passes, they can then use that as sort of the shell with which to pass further COVID relief. And that's why it's also really important to make sure right now, because that our priorities are known, because this is why the times during which members of Congress and the committees that are writing the bills are deciding what they're going to propose, in addition to the framework that the president has proposed, which wasn't specific on some certain line items. So we'll be waiting to see. Otherwise, they still are just finishing up organization. The Senate Democrats just announced committee assignments like yesterday, and I don't even know if the Senate Republicans have finished announcing theirs. The committees in the House are also still organizing. So there hasn't been much movement on other legislation so far. And then the last thing I want to mention is a series of executive actions that have been taken by the president so far. So those range from appointing a COVID-19 response coordinator and ensuring a data-driven response, reopening, or his executive order was to suggest that they reopen healthcare.gov and have a special enrollment period, which was granted. So from February 15th to May 15th, there will be a special enrollment period for plans on the exchange. There was 2 executive orders that related to federal funding for organizations that also provide abortion services. Of course, federal funds still can't be used for that purpose due to other restrictions, but this would remove some restrictions from funds going to organizations that, in addition to other services, do provide abortion services. There were a number of other executive actions that were taken. One that would revoke the executive order that limited the ability of federal agencies and contractors to hold diversity and inclusion training, which AMCHP had been very concerned about when that initial executive order had been signed under President Trump. So we are on record, having opposed that, and it was actually in our priorities for the administration, suggesting that it be rescinded. So we certainly are happy to see that it was. There's also a federal government-wide approach to advancing equity, the establishment of an equitable data working group, and then finally, a task force to unify families that were separated under the previous administration's immigration policies. And likewise, AMCHP had vocally opposed the separation policy. And so we are glad to see that there's progress forward on unifying families that, are still haven't been reunified. With that, I will turn it over to Laura Kavanaugh, the Deputy Associate Administrator for the Maternal and Child Health Bureau.
Thank you so much, Amy. I have a few updates for you today, and then I'm happy to take any questions that you might have. Could we move to the next slide, please? First of all, I'm very pleased to share that the Title V block grant guidance has been approved by the Office of Management and Budget. It's now available to you on the resource page of the Title V information system. We will be sharing with you the due date for the submission as we work through that process, but we wanted to make the guidance available to you. This is the guidance that you'll be using for your fiscal year 2022 block grant application and your 20 annual report. Next slide, please. In setting up the updates that many of you will be providing later about your COVID response, I just wanted to make sure that you were all well aware that Title V allows states to redirect Title V funds to support your needs in responding to emerging issues such as COVID-19. This is very flexible as long as you meet the major requirements like your 30-30-10 funding restrictions. You can use Title V funds for a number of activities. So for example, your response might include offering support for Title V epidemiologists in partnership with other state staff to do outbreak investigations or contact tracing. You can work closely with your state or local emergency preparedness staff to assure that the needs of the MCH populations are well represented. You can fund infrastructure to support the COVID-19 response directly. So for example, public health nurses who are routinely supported through the Title V program can be mobilized using Title V funds or separate emergency funding to support, deliver healthcare services or to staff call centers, et cetera. We have also seen states use funds to partner with parent networks and healthcare providers to provide accurate and reliable information to all families. So on vaccines and upcoming issues as well, those funds can be used for those purposes. also. If you have any questions about the use of funds, you can reach out to your project officer or your regional MCH consultant, and they'll be happy to have a conversation with you about the flexibilities. Next slide, please. We have an upcoming Title V partnership meeting series. We've held one of these 4 virtual sessions so far to discuss emerging issues for Title V. Our next session will be February 18th from 3 to 4 p.m. Eastern, and the topic will be COVID-19 and Title V. There will be a special breakout for SSDI directors. We want to make sure that encourage your participation at this upcoming session on February 18th. Registration links have been sent out via AMCHP as well as the MCHB listservs. And if you have any questions about the meeting series, please contact Erin Patton on our staff. Next slide, please. Just a few opportunities that I wanted to make sure you are aware of. We've discussed several of these in previous presentations, but wanted to make sure you are aware. The National Academy for State Health Policy is sponsoring a maternal mortality policy academy that will run from April of 2021 through March of 2023. If you're interested in participating in this policy academy, and they'll be taking up to 8 states, please make sure that you submit your application by February 26th. The P4, or Promoting Pediatric Primary Prevention Challenge, is now available, and submissions are due by March the 15th. Dr. Warren has discussed this in previous AMCHP calls. And the last opportunity is an Emerging Issues Notice of Funding opportunity. We'll be making 6 awards of up to $250,000 each to address emerging issues that you see within your state or locality. The applications for these are due April the 9th of this year. And that's all I have for you today. Thank you so much. And we look forward to the continued conversation later on in the webinar.
Great. Thank you so much as always, Laura. Really appreciate it. Next, I'm going to turn it over to Dr. Karen Remley, who's going to introduce our CDC guest speaker for today.
Everyone. It is with particular pleasure that I get to introduce Dr. Dana Meany-Tellman. She is, as you can see, an OBGYN, and she's still practicing. She's also a very important leader in our center. She's the chief of the Infant Outcomes Monitoring Branch in the Division of Birth Defects and Infant Disorders in the National Center for Birth Defects and Developmental Disabilities. She founded her branch under her leadership, founded the Emerging Threats to Mothers and Babies Initiative, which identifies and responds to emerging and re-emerging infectious disease threats, collects data on the effects during pregnancy, and translates that data into clinical guidance. They've also done work looking at the opioid epidemic and the impact that has had on pregnancy and on babies. And most importantly, what she's here for today, I have to say she is a true leader in the CDC response to COVID-19. She has spent 9 months there as a principal incident manager, and most recently as one of the co-leads for the vaccine task force. She has been passionate and very informed and very persistent, bringing science and evidence to the table to talk about clinical guidelines for pregnant and lactating women with COVID-19, and then also for vaccination, in concert working closely with ACOG and ACIP in order to bring this forward. And I wanted a chance to introduce her because I'm so very proud by what she does and humbled by it. And I think it has such big ramifications for all of us on the call who are women, and for the future of treating women of childbearing age as equal decision makers, owning their body, their decisions as anyone else in our society. And Dana is a champion for that. So with that, Dana, I will turn it over to you. And I learn something every time I hear her speak. So I'm excited to hear this.
Thank you so much, Dr. Remley. I really appreciate that introduction. I want to thank Amy and others who invited me to speak today. And I'm really excited to have the opportunity to talk with you all and partner with you all as we continue to face this COVID epidemic, but with some hope in sight. So I'm going to briefly talk about sort of the general COVID-19 vaccine implementation efforts. But because of our passion here, I'm going to talk specifically about some of the implications for pregnant women and some of the efforts that CDC is doing, and sort of predict what I think you might be seeing in the next couple of months in terms of questions and emerging issues that you may face. I hope at some point we can come back and talk about COVID-19 vaccine in children, but right now that we don't have an approval for COVID-19 vaccination or an EUA for COVID-19 vaccination, but that's something that I think is going to be of interest. There is some work going on now, but I think I'm hoping we can get invited back to talk more specifically about that at a later time, because that is an important piece. Next slide, please. So just in terms of where we are with things, 55, almost 56 million doses of vaccine have been distributed. At this point, we're at about 34 million total doses administered. So this was at the beginning of the release of these two vaccines. It was over the holidays, but now we are administering about 1 million doses per day. Actually, most days even exceeding 1 million doses per day. And you can see there the distribution of those who have had one dose versus number of people receiving 2 doses. So one of the commitments in the vaccine distribution and initiation was that if someone got a first dose, we needed to ensure that they could get the full series, since the 2 mRNA vaccines currently that are under emergency use authorization both require 2 doses to really achieve vaccine effectiveness. So it's ramping up. We still have a long way to go, but definitely making good progress in terms of vaccine distribution overall. Next slide, please. So just to go into a little bit more detail about these vaccines. So these are under an emergency use authorization. I think there's been a lot of confusion about emergency use authorization. So I do want to emphasize throughout this talk, and happy to take questions, that this process was an extremely rigorous process to look at these vaccines. So there are 2 on the market currently in terms of the ones we're releasing. Pfizer BioNTech, which is 2 doses of vaccine given at least 21 days apart, and then Moderna, 2 doses given 28 days apart. And the goal really is for people to receive 2 doses of the same vaccine if at all possible. These vaccines were tested in tens of thousands of adults. And I think one of the myths that's out there is, these were pushed through very quickly because of the terminology Operation Warp Speed. And really, the testing and the analysis of efficacy and safety was really held to a very rigorous standard, the same standard we would for licensed products. However, what was functioning at Operation Warp Speed, to use a Star Trek term, was the manufacturing. And so often it takes a long time to manufacture vaccines, but the US government invested billions of dollars to ramp up manufacturing even before we had vaccines. So that's really where the emphasis and the rapidity came into play. Both have clinical trial data that have shown both vaccines are safe and effective at preventing COVID-19. So they were specifically looking at severe COVID-19 as the outcome of interest to prove they were efficacious. And we do have data on immune protection, but we really don't have long-term data. So the data we have is in months, not years, in terms of how long the immunity from COVID-19 lasts. The vaccines do contain what's called a lipid nanoparticle, which boosts the immune system and is at least showing antibody responses that are similar to the disease itself, and maybe even a little bit better in terms of the immune protection. Next slide, please. So when releasing vaccines in limited supply, we needed to do some thinking both in the Advisory Committee of Immunization Practices and also at the National Academy of Medicine and Science and Technology. Needed to do some thinking about, if we don't have vaccine for everyone on day 1, how would vaccine distribution be prioritized? So the The Advisory Committee on Immunization Practices is an external federal advisory committee to CDC that makes recommendations to the CDC director, which are ultimately put forth and signed off on by the federal government, including the HHS secretary. And so the ACIP recommendations are guidelines. States can choose to put folks in different priority groups, but the idea behind this advisory committee of immunization practices and prioritization is to ensure that we look at the data in a transparent way and have input from all sectors of the nation, including the patients themselves, healthcare providers, ethicists, et cetera. So these are the phases that the ACIP recommended based on their ethical framework. Phase 1A includes healthcare personnel and long-term care facility residents, and most states are in Phase 1A. Some states have added other populations to Phase 1A. Phase 2 that ACIP recommended was frontline essential workers and persons aged 75 and older. Phase 1C is persons aged 65 to 74, persons aged 16 to 64. One of the vaccines is approved for 16, 17, and 18-year-olds. So that's where that 16 comes in, as well as for essential workers not recommended in Phase 1B. And then Phase 2 was all people age 16 and older, not included in Phase 1 who are recommended for vaccination. And as you can see from the bottom graph here, that really these phases are overlapping. They were never intended to be discrete, because the primary goal here is not wasting any vaccinations, because we know that we need about 70% of the population to be vaccinated to achieve immune protection and to really knock out this pandemic. So the intent here is that these phases would be overlapping, and that states can choose to adopt these exact priority groups or can make modifications based on their own population. Next slide, please. So just to outline the guiding principles of how ACIP came up with these recommendations, the first was efficient distribution. So during a pandemic, efficient, expeditious, and equitable distribution and administration was critical. So really, as they were deliberating the various priority groups, they thought through how would this actually be implemented. They got a lot of input from state and local partners in terms of how could this be implemented when we know that the numbers of doses would not be enough to vaccinate the entire population. So thinking through the actual numbers and then how this would be implemented at a local level. And then the second main guiding principle is flexibility, which is what I alluded to earlier, that these are national guidelines, but that we know state and local jurisdictions need the flexibility to administer vaccination based on local epidemiology as well as demand. We know there are communities where the demand for vaccine is not quite as high, and therefore we would not want those vaccines to go to waste. So moving through the next priority population is what's recommended. Next slide, please. It's really important that I emphasize that, while COVID-19 vaccines were, quote, fast-tracked, safety has not been compromised. These are mRNA vaccines. They were developed based on years and years of research, and they used existing COVID-19 vaccine trials. And as I mentioned, the manufacturing is still underway and began even before completion of the trials. mRNA vaccines are faster to produce than traditional vaccines. Many vaccines are based on live virus, and you actually have to grow the virus. So because these viruses are not live virus, they are faster to produce than traditional vaccines. And in terms of the approval process, the emergency use authorization process, this was expedited through FDA, through CDC, not in terms of expediting the review of the scientific material, but just in terms of how frequently the meetings occurred and moving up people's schedules to ensure that this was the #1 priority for the country. Next slide, please. So a lot of confusion and myths are out there about mRNA vaccines. People hear the term mRNA and they think this is concerning with regard to genetic material. And so I just want to emphasize this a little bit for those of you who may have received some of these questions. mRNA is genetic material. It carries genetic material that teaches our cells how to make what's called a spike protein. So this is a harmless protein, which is found actually on the surface of the SARS-CoV virus. So this is not DNA. This is a message that exists in the cell that tells the cell to make this particular protein. It's not our genes, which are contained within DNA. This particular RNA, which is, think of it as the message that tells our cells to make the spike protein, is actually destroyed by our cells once copies of the spike protein are made and the mRNA is no longer needed. So 24 to 48 hours after receiving the vaccine, that little piece of mRNA is degraded and is gone. So I think that's really important to some of the myths that are out there about the impact of vaccines that are based on genetic material but aren't actually genes. Cells display this piece of the spike protein once it's made, and that tells your immune system to trigger an immune response. It's a foreign spike protein that your body hasn't seen before, or even maybe has seen before if you've had COVID, and it tells our body, oh, there's something foreign, and it begins producing antibodies which protect us from getting SARS-CoV virus in the future. So hopefully that specific myth about how it can change our genes has been dispelled for you. Next slide. Like all vaccines, as I said, it was rigorously tested before being authorized. The technology is new, but not unknown. And I think another myth that's out there is, well, it makes something, it makes a protein. Is this actually a live virus? Can you get SARS-CoV from the vaccine? And it is not a live virus, so it does not carry a risk of causing disease in a vaccinated person, and it doesn't interfere with people's DNA. Next slide. Safety is our top priority. Before the vaccines were approved, FDA and ACIP carefully reviewed all the data. The ACIP, as I mentioned, is an advisory committee to CDC, but there's also an advisory committee to FDA called the VRBPAC, and that committee met independently of ACIP. So 2 federal advisory committees reviewed the data independently before the vaccines were authorized and before recommendations were issued. And then after authorization, in the period we're in now, FDA and CDC are closely monitoring vaccine side effects and safety. And I'll talk a little bit about that specifically for pregnant women in just a moment. Some of these systems have been in place long-standing and some are new, which I'll talk with you about. Next slide. So I want to transition just a bit to maternal immunization. There's been a major emphasis and focus on maternal immunization, both national and international attention on maternal immunization that really began with H1N1 and has progressed substantially with COVID. And you may have heard about this. I was on a call, I think, with the MCHB work group, and this may be something you're familiar with, but the movement really is away from categorizing pregnant women as a vulnerable population, but rather to recognize that they have autonomy to make decisions about vaccination and to make informed decisions about not only vaccination, but also whether they want to participate in clinical trials. We know that to make informed decisions, there need to be data, and there need to be data not only in animals, but in humans, specifically as someone is making an individual risk-benefit decision about vaccination, either by themselves or in concert with a healthcare provider. And one of the prevailing tenets of maternal immunization is that women who are eligible for a particular vaccination should not be denied a vaccination or limited a vaccination because they are pregnant. And so they still should have the ability, like anyone else, to make a decision about vaccination. And you can see there on the right side, when making decisions about vaccination or really any intervention, any medical intervention, it's really looking at risks and benefits of the intervention, risks and benefits of not doing the intervention. And in this case, with the vaccine, it's looking at what are the risks of COVID-19 infection for the mother, what are the risks of COVID 19 infection to the infant. We know that vertical transmission can occur. COVID can pass from the mom to the baby. And then what are the benefits to both the mother and to the fetus or infant, balanced by what are the theoretical concerns about the vaccine. So these are the individual decisions that are being made with COVID-19 vaccination. Next slide, please. So part of the equation are what are the risks of COVID-19 during pregnancy, and through SETNet, which was mentioned, I think, by Amy early on. Thank you for the support of AMCHP, as well as by Dr. Remley. Our SETNet, our Surveillance of Emerging Threats initiative, has allowed us to capture data about the risks of COVID-19 during pregnancy. This was something that was initiated with Zika, and now we capture data about syphilis, hepatitis, and then rapidly transformed the system to incorporate COVID-19. And so we've learned through this system and through publications by many others that although the absolute risk of severe adverse outcomes is low with COVID-19 during pregnancy, pregnant persons with COVID-19 do experience severe disease. They can have a coagulopathy or blood clots, they can have preeclampsia, they can be more commonly admitted to the intensive care unit than women who are not pregnant. They can have more likely or are more likely to need mechanical ventilation or to be put on a respirator. They may need extracorporeal membrane oxygenation. This is a procedure that when someone has a respirator and they're still not maintaining good oxygen levels, they need to have this specific invasive procedure to maintain their oxygen levels. And then they have been shown to have a higher risk of death. So we know that there are pretty significant risks of COVID-19 during pregnancy. We also know that there's an increased risk of preterm birth. This is still being teased out in terms of how this relates to the severity of infection. But we have at CDC, through our surveillance system and many others, have demonstrated risks of preterm birth. And we know this disproportionately affects Hispanic and non-Hispanic Black persons. They have these more severe outcomes, including Hispanic and non-Hispanic Black persons who are pregnant. So that the racial and ethnic disparities that we've seen persist in pregnancy as well. Next slide, please. So when ACIP was making recommendations about these mRNA vaccines, people were asking, what about pregnant women? And so at the time, and still today, we have the animal data, and these are affectionately termed DART studies, which is the animal developmental and reproductive toxicity data specific to these vaccines. And these were conducted in rats. So these are pregnant rats. They look at the pregnant rats and they look at their offspring. And there are no safety signals with the Pfizer vaccine or the Moderna vaccine, either during pregnancy in the pregnant rats or in their offspring. And pregnant persons were specifically excluded from the vaccine trials, the Pfizer and Moderna vaccine trials. But as sometimes happens, some women did become pregnant after they were vaccinated between dose 1 and dose 2. So 23 women for Pfizer and 13 women with Moderna. And there have not been any safety signals among these women, but they have not, all of them have not completed their pregnancies. So we don't have longitudinal data yet. So we had to make recommendations about these vaccines during pregnancy. And so we really relied on the expertise of the American College of Obstetricians and Gynecologists, the American Academy of Pediatrics, our infectious disease colleagues. And we really thought about, well, what are these vaccines? What are the theoretical risks? What do we know about how quickly these vaccines degrade in our cells? So we know they're not live vaccines, and we know they degrade quickly by normal cellular processes, and we know they don't enter the nucleus of the cell. So these all informed the recommendations by ACIP. Next slide, please. So ultimately, the clinical considerations for COVID mRNA vaccination during pregnancy are listed here. If a person is part of a group recommended to receive a COVID-19 vaccine and is pregnant, the person may choose to be vaccinated. And a discussion with a healthcare provider can help make an informed decision, however, it is not required prior to vaccination. So being transparent about what we know and what we don't know about the disease, as well as the vaccination. And so some of the considerations as an OBGYN I have when I talk with my patients is I think about with them the level of COVID-19 community transmission, or what's their risk of getting COVID if they live in Georgia. What's their personal risk of contracting COVID, meaning are they staying home? Are they working? Are they a healthcare worker? What are the risks of COVID, which I discuss with them, and the potential risk to the fetus? What's the known efficacy of the vaccines? What's the known side effects? And being as transparent as we can about the lack of data. And I've had patients who have gone forward to be vaccinated, and I've had some that said, you know, I need to see more data before I'm comfortable. It's an individual risk-benefit decision. Next slide, please. So in terms of the safety component, CDC is monitoring the safety of COVID-19 during pregnancy. Next slide. So first is we're looking at VAERS, the Vaccine Adverse Event Reporting System, which is an established system. It's in concert with FDA and CDC, and it does include a question on pregnant women. So anyone can report an adverse event post-vaccine, and we're monitoring what's happening in pregnancy as well. Next slide. We also have the Vaccine Safety Data Link. These are 9 healthcare organizations across the United States. You can see them listed there that capture information about vaccines. So we're monitoring the safety of these vaccines and any side effects in pregnancy as well. Next slide. And so you can see the VSD system is monitoring the coverage in pregnancy with weekly counts of how many women are vaccinated. They're also doing a fetal death study, specifically looking at spontaneous abortion and stillbirths. And they're looking at a safety in pregnancy study, which is near real-time monitoring of adverse events during pregnancy. So it's a 5-year analysis that's being done in these participating centers. Next slide, please. We also have our Clinical Immunization Safety Assessment Group, which is a group that's been longstanding for vaccines, looking at vaccine safety, and they are planning an observational cohort study, which builds on their clinical research study. And again, this is specific to pregnant women, with Duke University in the lead, and with Cincinnati Children's and Boston Medical Center also participating. So 3 of these centers in this observational cohort study. Next slide, please. And then at CDC, you may have heard about the vSafe system. vSafe is a smartphone-based platform that provides active outreach in the form of text messages to those persons who have received a vaccine. Now here we're talking specifically about pregnant women, but anyone who's received a vaccine can participate in vSafe. There's specific questions in the vSafe smartphone system when people register that ask them if they're pregnant. So the first piece of this is we are monitoring for everyone, but again, for pregnant women, if they've missed work, if they've been unable to do normal daily activities, or if they've received medical care. And if they say yes to any of those questions, then our call center calls them immediately to follow up on any of these events and fills out that same form you saw as part of our VAERS system. And this involves a medical record component as well, so that the specific side effects can be ascertained through the medical record. Next slide, please. The second piece of this is a vSafe pregnancy registry. So in addition, when people sign up for the smartphone-based app of vSafe, it also asks them if they're pregnant at the time of their initial vaccination, or at their subsequent vaccination, or has there been a positive pregnancy test between those 2 doses. And if they answer yes, they get a phone call, which then invites them to participate in the COVID-19 vaccine pregnancy registry, which will involve a phone call every trimester, a phone call at delivery, and a phone call when the infant is 3 months of age. And then they also can consent to review of medical records that will occur at the conclusion of pregnancy or after the first 3 months of infant life. Next slide, please. So you can see here on the left, this V-Safe pregnancy registry will include those with a known pregnancy, those that are inadvertently exposed during pregnancy, and if someone is not pregnant but gets pregnant within 30 days from last vaccine, those individuals are invited to participate as well to try to capture that periconception period. Next slide. These are the outcomes we're monitoring, maternal outcomes, including anaphylaxis, which rarely occurs with these vaccines, but can occur even if someone is pregnant. And then pregnancy complications listed here, and fetal loss and infant outcomes out to 3 months of life, including birth defects. Next slide. And then finally, the last piece I just wanted to mention is CDC has had a long-standing birth defect study to evaluate pregnancy exposures through our center. This is an established case control study since 1975 that assessed risk factors for birth defects as well as stillbirths. And cases are identified through state-based birth defect surveillance systems in 7 states. There are controls that are selected from vital records, and this collects information for women who are recently pregnant via a telephone interview. We have added to this questions about COVID-19, as well as are in the process of adding the vaccine questions so that we can really compare between those vaccinated and those unvaccinated, what we're seeing in terms of birth defects. Next slide, please. So just in terms of vaccine messages, as you're out there and as vaccines become more widely available, it's really important to learn about COVID-19 vaccines. Hopefully some of this information you've known, and if I could clarify any myths, I hope I did today. Determine if vaccine is recommended for you, keeping in mind that this may differ based on what state you live in. Make sure you know the facts when you are being vaccinated, and receive. It's really important that if you're vaccinated, you receive that vaccine card. Right now it's a white card, and that's going to become very important, I think, as we begin opening up travel. You may experience some side effects. Those are not uncommon with particularly with the second dose of these vaccines, taking some of the anti-inflammatories, if you do experience vaccines, is something that can be done depending on the level of symptoms. And then enrolling in VSafe is pretty important. And then the last is to make sure you're still maintaining social distancing, mask wearing, because we don't know 2 things. We don't know how long the immunity is going to last. And as these variants are popping up, we're still needing to test all these vaccines against the variants that are coming about. So at this point, we're still recommending the mitigation measures that we were before. Next slide. So key facts. Getting vaccinated can help prevent you from getting sick. People who have already gotten sick may still benefit from getting vaccinated. We do know that people can get COVID more than once. The vaccines cannot give you COVID, and COVID-19 will not cause positive test results. I think that's another important point that we need to convey. Next slide, please. So vaccination is just one measure. We still need to do our mitigation measures, and you can see those listed here, making sure not only to wear the mask, but make sure the mask covers your nose and mouth, stay at least 6 feet from people, avoid crowds and poorly ventilated indoor spaces, and hand washing, of course, is critical. Next slide. So just a reminder, protect yourself, your family, your coworkers, get vaccinated if you're offered it, participate in VSafe, share your experiences, know the basics, and be proud that if you did receive the vaccine that you have, and show that to others. We still have quite a ways to go to promote vaccine confidence in this country to ensure we can get to that 70%. Next slide. And then these finally are just some CDC resources on vaccination for both healthcare professionals and for those communities listed here in terms of our toolkits. So thanks for listening. I don't know if we have time for a few questions, but we look forward to our ongoing partnership with you all, and happy to take questions.
Wow, thank you so much for all that wonderful information. We'll open it up for questions. Feel free to either type them in your chat, but please try to make sure to say all panelists and attendees when you type into the chat. You can also unmute yourself for Q&A. And while you're thinking about that, I'm also going to pose a question about if I can get the slides to advance. I think this was shared on the last call as well. We'd love to know about how your state and territory are utilizing funding from the Title V block grant to respond to COVID, or how you could use additional funding to respond. So right now we're open to questions either for any of our presenters who presented today or on these topics, and also on this information request from AMCHP, you can also send your responses in through the Google form, or even email them directly to Allison or to me. Thank you, Jess, for putting that in the chat. Well, I will say I learned something new, Dr. Minidella, because I've been wondering that same question too about could people test positive? You know, you see, it becomes a big story every time somebody tests positive after they've already had their vaccine. So it's helpful to understand that no, like having had the vaccine couldn't cause you to test positive. And I see we have a question from Connie Mitchell. You should be able to unmute. Or Jessica, can you help me with that? Connie, did you have a question?
Yeah.
Okay, there we go.
Can you hear me now? Okay, thanks. It said that you were muting me and maybe I was muting you. I really appreciate the presentations today. I am learning as fast as I can. We're trying to prepare, I'm from California, I'm the Deputy Director of Family Health in California, and we are trying to prepare some information for women, especially women who are, you know, now in our priority listing for receiving a vaccine, just in case they are pregnant or trying to get pregnant, and giving them some of this important information. But I will tell you, I've gotten a few questions. A question that I have not been able to answer, and that's a question specific to the Pfizer and the Moderna vaccine, and that's about the nanoparticles that they deliver the messenger RNA. It sounds like there's good information about, you know, the about the messenger RNA and what happens to it, but I'm getting a lot of questions about the nanoparticles, because there is some research in mammalian models where the nanoparticles can cross both the blood-brain barrier and also the placental barrier. So I just wanted to raise that up to see if there's any information or assistance you can provide to me. Thank you.
Great, thank you. So I have to admit, I'm not a nanoparticle expert. I don't know if those people exist, but my understanding, because I've raised this question as well, is that all of the vaccine components are degraded quickly. First of all, they don't leave the muscle area, so it's not like they're picked up and moved throughout the body. I've actually raised this question with even the vaccine manufacturers. My understanding is the nanoparticles, as well as the mRNA, are rapidly degraded within that local area. So it's not like they're picked up and moving throughout the body. So I don't know if that helps you in terms of A, they're broken down, they're no longer there, and B, they're localized. So I think that may help with some of the questions that you're having.
Thank you. Yeah, the degradation was what I could not get confirmed.
Excuse me. We have a question from Marilyn in the chat, and she asks, what is the recommendation if it is thought that a person being vaccinated has only gotten a partial dose? I guess the example is vaccine was seen running down their arm. Is there any problem with repeating this dose and then giving another dose 3 weeks later? Pfizer.
So it's interesting, the running down the arm, because this is a very teeny little bit of vaccine. It's only 0.3 cc's. So I'm a little perplexed by that, just in general, given the amount. But if the person giving the vaccine, says, I don't really think that, this went into your arm when it was supposed to, because the only way I could think of that happening is they actually, injected prior to it being, in the muscle. So I don't think there's a problem with giving it a second time. The repeat first dose followed by the second dose. We've had folks who have been concerned about the first dose, There are ways to test antibodies after the second dose to confirm, but there isn't a widespread use of antibody testing post-vaccine at this point. In the case you're describing, it just makes sense to just repeat the first dose and followed by the second dose.
Great. Next question from Patricia. First, thanking you for an excellent presentation. Can you share plans about messaging for pregnant women to receive the COVID-19 vaccine?
So there are a couple of things in the works. We do have guidance on the ACIP website as it pertains to pregnant women. So the clinical considerations, if you were to Google ACIP, there is some information there. But there are some plans in the works for toolkits that are more directed to patients. There's also, just as of yesterday, actually, a wonderful list of 8 tenets for vaccine centers to use when they're vaccinating everyone, but specifically pregnant women. So for example, you don't need a pregnancy test before you actually get vaccinated. You can talk to your healthcare provider, but it's not required for you to talk to your healthcare provider. Here's what we know about the limited safety data, but here's what we have thus far. So sort of some of these pieces were actually just put out last evening publicly by the American College of Obstetricians and Gynecologists. So there's both work from ACOG that's out there, and they're very prolific in this area. And then there's also toolkits that CDC has and is working on. But if there are specific requests, we need this, we're certainly open to that. And in previous responses, for example, during Zika, we've said, tell us what you need, and we can tailor things to the needs of your particular population. So if you have ideas, please let Amy know, and we can pass that on for things that are going to be most useful in your setting.
Great, thank you. And thank you, I think that was Dr. Carlos who shared the ACIP vaccine recommendations link. There was also a question about data related to the impact of COVID-19 and pregnant American Indian women.
So I'm sorry, I'm not following specifically. I mean, let me say it this way: with the vSafe registry, we are capturing, and hopefully, as this continues to roll out and more vaccines become available, we are capturing in the pregnancy registry race ethnicity data to ensure that we can understand all populations. But I didn't know if there was a specific concern.
And I think this was generally about the impact of COVID-19 in this population as opposed to just the vaccine and vaccine safety.
Oh, I see. So it's a great question. In our SETNet data, we had a very small percentage in the initial data, but I think it would be worthwhile to look back now. I don't know it off the top of my head, what we know specifically broken down by that population. So I don't have an answer for you, but I can certainly bring it back to our SETNet group and see what kind of data we're looking at now that I think there's about 11,000 women in the SETNet COVID-19 registry. So I'll have to get back to you on it, but it's a great point. Thanks for raising it.
Okay, Noel asks, I know I work with children, but is there any concern with second dose effects on individuals over 80? And I will add, my grandparents actually just got their second dose on Tuesday, and they are in their early 90s. And I mean, I don't know, maybe it's because they have other comorbidities, but they haven't really had any bad side effects so far, but I know it's, changes.
Good. So let me just say, we're not seeing a lot of people with bad side effects. We're seeing people with things like soreness and discomfort. So I think people make sort of a jump, and I don't know if you were alluding to this, but even myself, I was like, wait, my arm is not sore enough. Am I getting a good reaction? There's no correlation between the absence of sort of side effects and a diminished antibody response. So don't worry that it's not effective. I mean, we do know that as people age, their immune function is not quite as robust as it is when they are younger. But the clinical trials did include older individuals. I can't off the top of my head tell you what the percentage was, but I think we're going to know more as we do what's called vaccine effectiveness trials, which are not clinical trials, but it's what we do at CDC, where we follow the actual effectiveness. And, I think we'll get at this issue of whether people will need a booster, and if so, what groups of people may need a booster. But at least right now, because of the technology that we're seeing, it seems there's a robust immune response that occurs in both the vaccines, even among older individuals.
Thank you. A question from Elizabeth is, are there human cells found in any of the vaccines? And if you already answered this, I apologize.
No problem. No human cells. Zero. Uses your cell machinery with those little messages to make the spike protein. So no cells.
Great, thank you. Well, we have about 5 minutes left. So again, if there's any other questions for our presenters, please continue with those. But we'd still also love to hear answers to our request for info on how you're using your Title V funding, or really ask if you could please email Allison or me, or use the Google form to share that information as well. I know there's also going to be a lot of more information sharing just as part of other coalitions, and also with Capitol Hill, to make sure that we're keeping the specific needs of MCH populations as relate to COVID in general, and especially with vaccination front and center. So lots more good information coming out. Also a reminder that our next call will be March 4th. We're transitioning now to once a month in 2 weeks from now. For those of you who are going to be involved, instead of this call at 2 o'clock on Thursday, the 18th, it will be the TA partnership call being held. So our next AMCHP policy call / COVID town hall will not be until March 4th. But we always accept suggestions for speakers and topics. But I know vaccines was a big topic that folks wanted to hear about, and we just really thank you so much for sharing your expertise and your time with us and answering questions. I'll give folks another minute. Annette, regarding the presentation, we post them all to the AMCHP website, and you'll be emailed a copy of it as well. So make sure to look for both your email or check back on the AMCHP website within a few days. Or you can always email Jess Cohen as well, and she'll make sure that you get a copy of it.
Amy?
Yes.
This is Karen. I just wanted to throw out there, I didn't see somebody ask it, but I have people ask me all the time. There are no aluminum nanoparticles in this vaccine either. Sadly, there has been some social media that has actually targeted people who have come from Africa. And so communities around the country that have, from the African diaspora, that may have a community, close-knit community, especially Northern Virginia, saying that there's aluminum nanoparticles that will cause Alzheimer's. There is no aluminum, it doesn't cause Alzheimer's, but it's very scary when people, send around social media that looks like somebody official saying that. So I just want to say out loud, yes, know that is false. And then people ask about, that there's somehow a chip, some sort of a nano computer chip that will allow the government to know where I am. We smile, but some people have real concerns about that. And so I think it's really important to be able to address head on, that does not exist either. Because I think all of us sometimes forget that we're close to the science all the time. And many people really don't have an understanding of how vaccines work or what might be there. So, whatever we can do with those simple, straightforward messages for people. I think the other thing that is really important is once you're vaccinated, you become an influencer for the people around you. And the best testimony to getting vaccinated is saying, I've asked as you said, your grandparents have gotten vaccinated. I'm standing in line for my turn and I'm driving people there to get vaccinated when they need to be. That's an important part of what we all can do to help women and children too.
Absolutely. I know friends and family who are physicians were telling me that their professional organizations were doing a really good job of making sure they know to post their selfies on social media and share it with everyone. So really helpful. And Dr. Carlos says, thanks again, very informative. And and great lessons to have learned from working on Zika as well. And so, all right, it's 2:59.
That's my pal.
Yeah.
Hello. We haven't, it's such a small world. You wind up seeing the same people over and over again. So it's good to hear from her. Just one other thing I just wanted to mention, which I didn't put on the slide because it's sort of breaking news. CDC is hosting a national vaccine forum, February 22nd, 23rd, and 24th. So information coming out about that. We've just gotten the actual approval and go ahead. So this will really be a call to action, bringing together various parts of the public health world, the clinical world, even some celebrities, from what I understand, to come together to really promote vaccination, because there are still many communities that are hesitant to receive the vaccine. And this is like many other things, really is going to take a village. So we all need to come together and, be transparent about what information we have and communicate clearly. So did want to let you know more information will be coming, but may want to hold those dates.
Yeah, please. If someone from CDC could send us information, we'll be sure to share that on our channels as well.
Okay.
Great. Well, thank you everyone again, especially to our wonderful panelists today. Really great information. Everyone will receive copies of the slides in your follow-up email. And again, the recording will be available on the AMCHP website within a few days. And we will see you all next month. Have a great rest of your day.